I knew my only chance at survival would be to study my samples, to understand what my immune system was doing wrong, and then try to understand, are there any drugs already out there that can maybe fix the problem? If there's too much of something, is there a drug that'll make less of it? If there's too little, is there a drug that'll increase it? That's as simple as it was.
Welcome to the Business of Healthcare podcast from the Center for Healthcare Leadership and Management. The center is based at the Naveen Jindal School of Management at the University of Texas at Dallas. The show, like the center, brings together business leaders and other forward thinkers to discuss how best to meet the challenges of a rapidly changing, increasingly complex healthcare industry. I'm your host, Dr. Bob Kaiser, Director of the Master's Program in Healthcare Leadership and Management for Professionals.
Today, we have an opportunity to have a discussion with Dr. David Fegenbaum. David's not an ordinary person and certainly not an ordinary doctor. He's been profiled by all the major media outlets, Good Morning America, The Today Show, CNN, Fresh Air, New York Times, and many, many more. We're here today to have a discussion about his national bestseller, Chasing My Cure, A Doctor's Race to Turn Hope into Action. But even more importantly, to discuss the process of crowdsourcing solutions for orphan diseases. Welcome to the Business of Healthcare podcast, David.
Thanks so much for having me, Bob.
Well, David, I've read your book twice. Actually, I listened to it twice, where you are the narrator. So in my mind, I feel like I actually know you. I know your story quite well. You are a patient with a deadly illness that's nearly killed you 5 times. And you're also a physician, scientist, racing to discover a cure before your time runs out. I think we have to start with your story to set the foundation, but we'll leave our listeners to learn more details within the 18 chapters of your book.
Sounds great.
Why don't you start with your story, David?
Be happy to. And again, thanks so much for having me on. I'm really excited about this conversation. So as you mentioned, I am a patient with a rare illness. I went from being this healthy third-year medical student. I was training to become an oncologist. I wanted to treat cancer patients in memory of my mom, who had passed away just a few years before. When out of nowhere, I became critically ill. My liver, my kidneys, my bone marrow, my heart, my lungs, they all just started to shut down. And for no known cause, we didn't know what was causing all of these problems. And then, of course, I was hospitalized. I was admitted to the intensive care unit. I gained 70 pounds of fluid. I had a retinal hemorrhage that made me blind in my left eye. I was so sick, as you know from reading Chasing My Cure, that a priest came into my room and read my last rites to me when the doctors were certain that I wouldn't survive. And so through the course of this illness and these many low points, I learned so many lessons about life and about living from nearly dying, and lessons that fundamentally changed who I was. So when we eventually got the diagnosis and I was eventually treated and survived thanks to these treatments, I felt so compelled that I needed to share these lessons with the world, which is, as I mentioned, why I shared my story through the book. But as you know, getting the diagnosis was just the first step. That was almost the starting point, was getting the diagnosis of what this was. But my journey continued with trying to figure out, how do you treat idiopathic multicentric Castleman disease? What's going wrong in patients like me? And how can I be a part of searching for a treatment that could maybe save my life, which I eventually did?
Well, discovering the fact that you had this rare orphan disease called Castleman disease, I believe it started back in the early 50s. And it's so named after the doctor that was working with it at the time. Looking at that as a disease, understanding that there's no data on that or no resources on that, how did you ever come up with the idea that truly was the diagnosis?
It was, as you said, the first step is diagnosis, and it wasn't easy to make. Castleman disease was first described, as you said, by Benjamin Castleman back in 1954, and he described a group of patients that were just like me. Got sick out of nowhere, our organs shut down. We had big lymph nodes throughout our body. And the reason initially that those patients were evaluated is that everyone thought they had lymphoma. And the same thing happened with me. All the doctors, we all thought that I had an aggressive form of lymphoma, but it was when the lymph node was taken out and the doctors looked under the microscope at the lymph node, they said, okay, it's not lymphoma, a cancer of the lymph nodes. It's actually this immune system problem where Castleman disease, the immune system gets out of control. So it's actually, my immune system is too strong. It's so strong that it actually attacks and shuts down my body's vital organs. And that sort of understanding and figuring out a pattern, finding other people with similar symptoms is the first way you start to think about, well, what a disease is. But it wasn't until several years after I was diagnosed with Castleman disease that I led an effort to bring together physicians from around the world to actually establish a criteria. How do you diagnose Castleman disease? And so that's been out for the last few years. And it's just been amazing to see patients that get diagnosed within 2 days of showing up to the hospital. Whereas for me, as you'll remember, it took weeks and weeks before I was finally diagnosed.
Well, when we look at your life story, and that in itself is an interesting story, independent of having the disease, just the things that you went through. And not to go into too much detail, but we talk about how you were before you got this disease. I saw pictures of you on the website. You were the beast. You're the quarterback, a weightlifter. You're a quarterback, for your college team and at Georgetown. And you were like this amazing 6'3", incredibly strong, healthy person. And then I see that contrasted with your picture with the disease, where you have 70 pounds of bodily fluid, and you would never, ever recognize the two. You just totally two different people. And I've heard it said that, you look at your life, you've had the healthy life, the sick life, and the fighting back life. And I'd like to learn a little bit more about the fighting back. How come you're not dead? I mean, the fact of the matter is, all odds were against you to survive this particular type of Castleman's disease, right?
That's exactly right. And just as you said, I really do think about breaking my life up like that. And there was the fighting for survival, which was that second part, which is when I was in the ICU and I was having my last rites read to me and I was getting chemotherapy and I was kind of just fighting for survival. And then I got a lot of chemotherapy, and that chemotherapy put me into remission for about a year. And for a year, I came back to medical school at Penn. And for that year, I was hopeful that I would stay in remission. I was actually on an experimental drug that was undergoing a clinical trial. And I really hoped it would keep me alive and healthy. And unfortunately, about a year later, I relapsed on that drug. So the only drug that had ever been studied for Castleman disease wasn't working for me. And I was just so disappointed, so kind of broken to my core that basically my only hope wasn't coming through. And I learned that literally sitting in the hospital room while I was getting chemotherapy infused into me. My dad, my sisters, and my girlfriend at the time, Caitlin, were sitting beside me. And when my doctor left the room after he explained to me that I was out of options, I told them, and I had not thought about this before, but I told them, I said, I'm going to dedicate my life to trying to find a treatment that could maybe save my life and patients like me. I think my family, they knew that I would fight for this, and I knew that I would spend my time fighting for it, but none of us, I think, expected that I would be a part of finding something that could save my life. Maybe the work that I did could save someone in the future, but certainly I don't think we imagined that it could actually have a meaningful impact on my life. But we did get involved in this fight, and that was first starting a foundation called the Castleman Disease Collaborative Network. And then when I relapsed again, it was utilizing the samples that I've been collecting, blood samples, lymph node, bone marrow that I've been collecting, and actually running experiments on my own samples to try to see if I could figure out, are there any drugs that are already FDA approved for something else that could maybe be helpful in my case?
So you were at the end of your rope. There's no doubt about that. I think the way it was phrased, it was the fifth overtime.
Right.
The ball was in your hands, and you had to do something to bring this thing together. And so you collected all of your different history, your specimens. You started pulling together all the research, all the information. You took ownership because there was nothing out there for you. So that is a compelling story. And I think it leans back to an earlier stage in your life. And I know that your mother had passed away with cancer. And as a young student, you were grieving, and you put together this ties in, I think, to this network that you built later for the Castleman's disease, but you put together a nonprofit for grieving students. You were grieving the loss of your mother, and you put together a program called Actively Moving Forward, the same initials as your mother, AMF, Actively Moving Forward. Tell us about that, and what did you learn from that? And I'm going to share with you what I learned from that.
Sure. So just as you said, when my mom was diagnosed and when she eventually passed away about a year later from her cancer, I was just devastated by that experience. I mean, it was it was so heartbreaking to lose such an incredible person, and my mom. It was heartbreaking. But kind of similar to when I learned that I was out of options from my health perspective, when I was at my lowest point after my mom's passing, that's when I realized that there were a lot of other people just like me at Georgetown, and all of us were suffering, and all of us felt completely alone. And unless one of us or some of us came together, we would continue to feel alone. And so I promised my mom, actually just a couple of weeks before she passed away, that I would create something in her memory. And I told her I would call it AMF. I didn't know what AMF would stand for, but I did want it to name it after her. And this final promise to her became my life's mission, bringing together college students to support one another through the most difficult times of our lives, and to not just support one another, which of course is so critical, but also to channel our energy towards making a positive difference in the world. So I lost my mom to brain cancer, so I would get all of my fellow members together and we would go raise money and awareness for brain cancer research. And someone else in our group lost her dad to ALS, so we went to ALS events and raised money and awareness for ALS. And the idea was that could we support one another in a support group, but could we also channel our energy towards something positive, such difficult grief and sadness, towards something that could be positive. And so, as you were alluding to, I think there were a lot of parallels, because I found myself at my lowest point with my doctor explaining to me that I was out of options and that I was going to relapse and I would eventually die once the chemotherapy no longer worked. And at that point was when I realized that A, there were a lot of people just like me who also were struggling with this disease. And B, if I had any hope for a future with my incredible girlfriend at the time, Caitlin, with my family, who I love so much, if I was going to hope that there could be a future for me, I knew the only way there could be a future is if I started taking action and if I started turning my hope into action.
This episode is brought to you by the Center for Healthcare Leadership and Management, the definitive resource for healthcare management education in North Texas. The center is based in the Naveen Jindal School of Management at the University of Texas at Dallas. It plays a unique role in training the next generation of healthcare leaders to meet local, regional, and national demands. The Jindal School uses its strengths in accounting, administration, finance, marketing, and information systems to educate highly qualified personnel for healthcare administration and executive leadership positions. The center is home to 7 healthcare leadership and management programs, including undergraduate and graduate programs, as well as executive programs for physicians and working professionals. For more information, visit us online at jindal.utdallas.edu/healthcare.
The word collaborative, which shows up now in CVCN, the Castleman Disease Collaborative Network, that word collaborative got its origin really in the beginning with your Actively Moving Forward, AMF group of folks, which I think is important. So what I got from this, one of the messages that you had learned, you said, about formulating the Actively Moving Forward was that to get people to listen was pretty easy. You could get them to pay attention, but was really difficult to get them to take action, to actually move into a direction of doing something. And I can tell you that influenced me to take action with your group. I really believe in what you're trying to do in this process. So when you stop and think about it, making that decision to move this forward in a meaningful way, that was not luck at all. I mean, you literally took on the responsibility. And I want to hear about, you talk about this in your book. We won't dwell on it too long, but I want to hear about your eureka moment. Mm-hmm. And I know there's 3 technical terms we won't go deep in, medical terms we won't go deep in. But if you would, share with us the eureka moment that resulted in you finding a drug, sirolimus, which is right down the street at the CVS pharmacy that has been working to save your life.
Sure, I'd be happy to. As I mentioned, when I relapsed and nearly died for the fourth time, I realized that the only way I could survive is if I got involved in searching for a treatment that could save my life. But I knew that there was no way I would be able to develop a new drug, test it, and get it, be able to take it myself. That route takes billions of dollars and many, many years. I knew my only chance at survival would be to study my samples, to understand what my immune system was doing wrong, and then try to understand, are there any drugs already out there that can maybe fix the problem? If there's too much of something, or is there a drug that'll make less of it? If there's too little, is there a drug that'll increase it? That's as simple as it was. But in order to try to figure that out, I needed to really understand what was happening in my own immune system. And so, as you mentioned earlier, I had been collecting blood samples on myself. So when I nearly died for the fifth time, I had already been collecting samples every few weeks leading up to me being hospitalized. So I all of a sudden had all of these specimens to work on, because I knew that if I survived that fifth time, the only way that I could prevent a sixth or a seventh or frankly, the end of my life would be if I could go back to those specimens and I could run experiments on them. And maybe I could get lucky and find something in those samples that could basically suggest that there was a susceptibility in my disease to a drug that already existed. And so I did those experiments. And as you mentioned, there was this really important eureka moment where the studies I had done made me think this one part of the immune system, it's a communication line your immune system uses to communicate with one another. And I suspected it was activated based on some experiments I'd run on my blood, but I had no proof yet. It was just a suspicion based on the data. And then I ran this final experiment where basically you do this staining process where if the cells have this communication line turned on, they turn brown. And if it's not turned on, they remain blue. And I did this experiment, and all of a sudden I could see right in front of me my sample, which was like blazingly brown, and all of the other samples, which were like bright blue. And I just remember being like, oh my gosh, the thing that I thought was on is on. And even better than that, as you know, there's a drug that turns that thing off. It's called sirolimus. It's really good at turning off that communication line. And so all of a sudden we said, oh my gosh, we've got a target and there's a drug. And as you know, I go into in pretty significant depth that this drug rapamycin has been around for decades, and it's got this amazing story. It was found on Easter Island by the Rapa Nui tribe, and so that's why it's called rapamycin. It's just this amazing story. And all of a sudden, I realized it's at my neighborhood pharmacy. It's within a mile of me, for this whole time where I've been nearly dying, and so I started taking it.
So if that happens for you with Castleman's disease, the likelihood that could possibly happen with other orphan, and somebody asked me once, they said, well, what do you mean by an orphan disease? I said, well, it's not an immuno disease, it's not a cancer disease, it's somewhere in between. So we call it an orphan because it doesn't have identifiable parents. But if that worked for you with Castleman's disease, why couldn't that work in other areas? And that kind of sets you up for the next level of your research, right?
That's exactly right. I mean, you're preaching to the choir by asking me that question, because I feel that exact same way. We shouldn't have to wait for a med student to get some rare disease to figure out that some drug could be helpful for that disease. We as a medical community need to figure out better ways to understand how to utilize old drugs in new ways. This drug had been around forever, and no one had ever thought to try it for Castleman disease. And so that's become really, more recently, part of my life's mission, is to figure out how do we make sure that every drug that the FDA has ever approved for anything, how do we make sure that every one of those drugs is utilized in every way possible? And I've got a few examples that your listeners are probably very familiar with. So one of them is Viagra, which we all know the initial purpose. It turns out, and it is currently approved for a very rare lung disease called pulmonary hypertension, idiopathic pulmonary hypertension. And it's life-saving for this rare lung disease. Of course, no one ever thought about that when it was first developed. There was another purpose for it. And then there's another drug called thalidomide that your listeners may be familiar with. thalidomide gained a lot of prominence because of how bad it was. It actually caused terrible birth defects in the 50s. People were born without limbs because of it. And so it was immediately taken off of the market because it was so bad. Well, fast forward 20 years later, and a group of researchers in Little Rock, Arkansas, figured out that it's this amazing anti-cancer drug, and it's really effective for a very common form of blood cancer called multiple myeloma. It has literally saved maybe hundreds of thousands of people's lives, maybe even millions of lives have been saved by thalidomide. That drug that was terrible, caused all these problems, it got repurposed for multiple myeloma, and it saved all these lives. And so this is a concept that it's not something that hasn't been done before, this idea of repurposing a drug. It's been done before, but it hasn't been done enough. And unfortunately, in a lot of cases, the incentives aren't in place. And that's why I was excited to come on your podcast and talk about the business of healthcare. The financial incentives aren't in place. If a drug is already generic and cheap and no one is making any money off of it, there aren't incentives to figure out new uses for it, because you could find a million new uses, but we're not going to make any money off any of them. So I'm not going to do the work to figure out the new uses. And that's where I think the federal government and foundations and academic centers like my own at Penn, that we need to step up. We need to step to the plate and say, okay, if this isn't going to happen on its own, whether it's philanthropists, as I said, or academics, we've got to step to the plate and say, the world deserves every drug that could be helpful for someone to help those people. You should not die from a disease if there is a drug that's available and it's at your neighborhood pharmacy that could help you that we just don't know about yet. And so that's become my life's mission.
Well, that kind of brings us to the topic of the Castleman Disease Collaborative Network. And I want to talk about this collaborative network. We could replace the word Castleman disease and put some other names in front of that collaborative network. But I want to kind of unpack a little bit about the value of this network. I mean, your statement there is you're trying to accelerate research and the treatment of that disease. But how do you go about doing that? And I garnished a few things, and I want you to kind of touch base on that, is that by having this network, you can get people educated. And not only that, you can connect them with the community. Mm-hmm. And you can get them access to the physicians and other clinicians. And you can provide them with informed research. And more importantly, you can get them to join the fight like you joined the fight.
Yep.
Now, to me, that is incredibly powerful. How do you go about expanding that and getting people to understand the power of that network?
You're absolutely right. And I think that the power of our network comes from the fact that all of the players are working together. So physicians, researchers, patients, loved ones of patients, we're all working together. And the way that we do that practically is we actually have an online discussion board where they can connect with one another. And maybe even more importantly, we go through an effort, we call it crowdsourcing, but it basically is where we just ask patients, physicians, and researchers, what research questions are important to you? What question, if answered, could be helpful for you and meaningful for you or for your patient? And getting those ideas for what we should do, and also getting priorities from patients on the kinds of things that we should be focused on, that helps us to establish what we call our international research agenda, which is a community prioritized set of studies that we fund and that we do, and we fund from around the world. But the big difference here and what's innovative is that research groups typically raise money and then invite researchers to apply for that money. I've got, $100,000 to give out this year. Who wants it? And then you pick from the best. But for a rare disease, you might have 5 or 10 applicants. Whereas our approach is to say, let's not just raise money and then say who wants it and pick the best applicant. Let's use the whole community to figure out what's the most important research that we can do, and then go figure out who's the best person in the world to actually go do that research. And then we give that person or that group the funding to do the most important work. And it's a really important shift from just hoping that the right researcher applies for the right project at the right time to figuring out what is the right project, who is the right researcher, and let's go do it right now.
Well, that kind of sets us up for the last discussion topic here, because most people don't realize that you took that approach recently with COVID-19. Tell us about what took place there and how you organized the team to look at some very special issues.
You probably remember, Bob, Friday the 13th of March of 2010. That was the day that the U.S. really shut down when COVID was first emerging. And I found myself, I was sitting next to my wife, and I found myself hoping and praying that some researchers somewhere would follow the work that we'd been doing for Castleman disease, would understand the collaborative network approach, would consider the fact that there are all these FDA-approved drugs that could be repurposed for Castleman disease, that would systematically track them, whether they worked or didn't work, basically following the playbook that we'd gone through for Castleman's and applying it to COVID. And about a minute later, I said, wait a minute, why am I hoping and praying for some research group to do it? I'm alive today because I started taking action on what I was hoping for. I got involved in the fight. Maybe rather than hoping and praying for someone else somewhere to do it, maybe I should join the fight. Maybe we should join the fight. And so I reached out to my team first thing Monday morning and basically got the team on board with joining the fight. Now, of course, at the time, I got commitment from my team to do a 10-day challenge. And the idea was that over the course of 10 days, we would go through all of the papers that had been published. So at that time, there were about 2,000 papers. Build an army of volunteers and team members, go through all the 2,000 papers and do two things. One, identify drugs that were being given to COVID patients. And two, and to see whether they're actually helping. And then two, see if we could figure out other drugs that maybe haven't been tried yet in COVID, but they're approved for Castleman's or whatever it may be that might be helpful for COVID. The idea of, again, looking at all of the approved drugs in our arsenal. And so we did that for 10 days and we learned a lot. First off, over 100 different drugs were tried in the first 3 months of the pandemic. 100 drugs were tried to treat patients with COVID. And we heard about a few of them in the news, like hydroxychloroquine and remdesivir and dexamethasone. They made the headlines, but the reality was they weren't the only ones being tried. Literally over 100 were tried in the first 3 months. And so we finished this 10-day challenge and we said, wait a minute, we now have the only database of the 115 drugs that have been used. And by the way, every day, hundreds of reports are coming out. And so if we don't keep on top of this, we don't know if anyone else will. And so we created the Corona Project, where we've been systematically tracking every drug that's been used for COVID-19 since the beginning of the pandemic. You can go to cdcn.org/corona and you find this incredible listing. It's now up to over 400 different drugs have been tried to treat COVID patients, and about a handful of them have been really effective. And the remainder, it's unclear whether they're helpful or not. But this is the kind of systematic approach that I think is critical. And you mentioned earlier, can we apply what we've done for Castleman's to other orphan diseases? Yes, but I think we can also apply it to common diseases, things like COVID. At the end of the day, we have to utilize resources as efficiently as we can. And whether it's common or rare, it doesn't matter. I think that you have to create these sort of systems to track what's being used and to systematically figure out what works and what doesn't work.
There was some correlation too about the quick reaction of the immune system with Castleman's disease and also with COVID, how it would, in some cases, overly aggressively attack the immune system. So that was a great common denominator for sure. Well, I got to tell you, the 6 most powerful words I think of in the human language are, you become what you think about. You become what you think about. And I can tell you, you've been thinking about a lot of things, David, and it's a great message for others to learn from. I'm so glad that you've joined our podcast, and it's going to inspire doctors and medical students and the many supporting clinicians and administrators in the healthcare field. And I encourage everyone to learn more. Obviously we want you to reference chasingmycure.com, so they can learn more about what's taken place and the things that will be taking place in the future too. So thank you again for being part of our podcast today.
Thanks so much for having me. And so just as you said, you can pick up a copy of Chasing My Cure at your favorite local bookstore, anywhere where you get it, and also chasingmycure.com. And maybe I'll close with my favorite. You had 6 words. I'll give 4 words. And that's turn hope into action. And I think that, whatever you're hoping for, whatever you're praying for, the next question is, what can you do to turn that hope into action? And I'm alive because I turned my hope into action. And I'm so thankful that you invited me on the podcast and I had the chance to spend some time with you.
It's our pleasure. Truly our pleasure. Thank you.
Thanks for listening to the Business of Healthcare podcast. Join us online at businessofhealthcarepodcast.com to find episode links, notes, and more. Be sure to subscribe to the Business of Healthcare podcast on Apple Podcasts or your favorite podcasting app. To learn more about the Center for Healthcare Leadership and Management, go to jundal.utdallas.edu and then search under the Center and Institutes tab on the navigation menu. Also, we want to hear from you. If you'd like to provide feedback, make suggestions for future guests or show topics, or just want to get in touch with us, email us at healthcarebizpodcast@utdallas.edu. Biz is spelled B-I-Z. And let us know how we're doing. I'm your host, Dr. Bob Kaiser, with the Center for Healthcare Leadership and Management, where we're leading change by changing how we lead.